share my screen. And thank you everyone for joining us on Saturday morning. Okay. So the epidemiology of tobacco and cancer, and where are we now? We only have 20 minutes, unfortunately, so I'll try to give you as brief but clear of an overview of all the aspects of the major aspects of this. Okay, so learning objectives. There are two, really to understand why tobacco smoking remains a public health problem, despite all the news you might hear about decreases, and to recognize the cancer sites that are associated with smoking. Although from the polling, it sounds like this is not really an issue, but maybe I'll hopefully leave you with some sort of new information. Okay. So you probably already know this, but just as a brief overview of what is epidemiology, I am a cancer epidemiologist, and we are studying sort of the distributions. So this could be frequencies, patterns of risk factors, of health-related states and events. So this could be just, again, behavioral elements such as smoking, healthy eating, as well as any sort of outcome, whether that's a disease or other outcomes that we like to conditions, quality of life. And when we say specific populations, because you really could break down the populations in any such which way. This comes down to location, sort of where we are, the neighborhood, specific sex, race, ethnicity, and age. And these are all very important because if we see that overall we are doing okay when it comes to terms of tobacco or some cancer sites, that might not be the case for every individual sub-specific population. Tobacco and tobacco use. So this is something you're probably all familiar with, but it is a plant that is grown for its leaves, and it's dried and fermented and then put inside tobacco products. Tobacco, as you all have clearly answered in the polls, does contain nicotine, which is highly addictive. And that is one of the problems because we measure nicotine as well as components of nicotine to assess how much one is consuming of tobacco. That consumption does help us get an idea of how much carcinogens they may be, an individual or a population may be exposed to. It's very hard to quit tobacco use because of this addictive quality. So it can be smoked, chewed, and sniffed. And then smoked tobacco products are cigarettes, cigars. These are all things that you might be familiar with. And I'm not going to get into some of the e-cigs because you're going to hear so much more about it. And that really has to do with nicotine. But I will be focusing today mostly on cigarettes. This is primarily because cigarettes are what is the most common form of smoked tobacco use right now. And it is easy in some sense to measure because not only can we ask someone about their cigarette use, we can examine sort of population sales of the product, and it allows us to quantify how much cigarettes may be being consumed by the population. So if we're looking at the trends of just how the use across the US, and the trends can do differ globally, but I'll focus on the US today at this time. So you can see that it was actually quite low. They used other forms as well, but then with the US entry to World War II, the Great Depression, and World War III, the US did provide cigarettes to the soldiers when they were overseas, and we did see a prevalence in the number of cigarettes that were being used. And then this is a really hallmark, a huge milestone in terms of public health. So in 1964, the Surgeon General report came out saying that tobacco is actually bad for you. There were some hints of it before. There were some, Dahl and Peto had found that smoking was associated with cancer, specifically lung cancer. But then really when the Surgeon General report came out, we did see a decrease in the use. And then there's been several other sort of milestones that include sort of taxing cigarettes as well as sort of public health efforts in reducing the types of advertisement that may have led to this increase. So that's here. So then I'll go one step back because as you can see, so this is 1950s and this is 1964. And now this chart, this is from the CDC, starts at 1955. And you can see that this is already where we're at the decline, where women have not yet reached their peak. Their peak was a little bit later. There was a delay because women did start smoking at a sort of a cohort effect where they started smoking later than men. but you can see that there's a decrease. So clearly, you know, it looks as if we're doing okay when it comes to smoking. If we also look at things that some huge milestones, this is cigarette warnings, the Minnesota Clean Air Act. There is the FDA approves nicotine gum use. So this helps with cessation products. And then also in San Luis Obispo, this is sort of the first area to ban smoking in public buildings. This includes bars as well as restaurants. And then we all know that other states or cities and counties have followed, so that even in Hawaii, we no longer can smoke in a bar. So you can see that this has all sort of contributed to the decrease. So then the question is, where are we now? As you could see earlier, you know, the prevalence of smoking was quite high. And now we have about 13.7% of adults who are currently smoking in 2018. And while this number seems quite low, this still is equivalent to 34 million adults in the US who are still smoking. And this is a problem for a number of reasons, but it also, cigarettes contain 4,000 compounds, 70 of which are known carcinogens, animal carcinogens. But, you know, just because it's 70, these compounds can lead to other compounds that are not carcinogens, can also lead to inflammation and irritation, as well as depletion of the immune system. And if we get into the population, so I said earlier, 13.7% of US adults are smokers. We can clearly see that across the populations, this prevalence is very different. So where you look at least American Indians and Alaskan Natives, they have the highest percent of adults who smoke. Multiple race ethnicities, when they report that, they also have a higher prevalence of smoking, and whites, as well as African Americans. So you can see that there is quite a number of disparities when it comes to just cigarette use in adults. And then if we want to break it down, this is US data, but if we're looking at just Asians and Hispanics, we know that clearly these are very heterogeneous groups. And if we look at Asians, again, here's the line of where the average age prevalence of smoking among Asians, that there are groups, whether it's single male Chinese or entire populations such as the Koreans, who are smoking at greater proportions above the average within the group. And this is according to US data. So these are the subgroups in the US among the Asians. And then on the right side, there's the Hispanics, and clearly that's different. So it comes from Mexican, Puerto Rican, Central South American, and Cuban. And there are a number of disparities in the proportion of which are current smokers in the US, and there are great differences between men and women consistently across most of these. You can see that men are always at a much higher smoking proportion than women, except with the exception of Korean Americans, who seem to have very similar prevalence of smoking. We are very unique being in Hawaii. So this is the data for Hawaii. And as you can see, again, Hawaii, this is just a snapshot. This does not capture all of the racial ethnic groups. I understand how heterogeneous we all are, but just to understand that you can see even within Hawaii that there is a great deal of heterogeneity across the populations. And due to the immigration patterns, this may not be also consistent with the entire US. Within the racial ethnic groups. So this is very important to examine when we are looking at prevention efforts, as well as understanding the diseases that may be associated with smoking. So in terms of risk factors for what puts you at risk for smoking or has a higher prevalence of smoking, we already went over that males do tend to have a higher prevalence of smoking, as well as race ethnicities. This includes Native Americans being the highest, although there are a lot of other racial ethnic groups that have a high prevalence of smoking. And then education level, which is associated with lower education levels, tend to have a higher prevalence of being a current smoker. Geographic location, so in the US, the Midwest and the South is associated with a much greater prevalence of smoking. Low income levels, and then other factors such as psychological distress, being uninsured, disabled, and they found a higher proportion among those that report being gay, lesbian, gay, and bisexual. So clearly there are a lot of pockets of populations that do need extra attention from a public health standpoint. So this is in part some of the research that we have conducted at the University of Hawaii Cancer Center. And why is this so important for health? So again, from polling, I think you all understand why, but right now, more than 480,000 deaths are are from cigarette smoking. So this could be preventable. If we add up just the smoke, the cancers, if we say other cancers and lung cancer, that comprises of over 35% of these deaths are due to cancer, smoking related cancers specifically. Heart disease, and then chronic obstructive pulmonary disease. Some of you may be more familiar with it as COPD or emphysema, chronic bronchitis. These are all diagnostic terms that relate to COPD. And this is also a known risk factor for lung cancer. And then I do have a slide later at the end that goes over the some little information on COVID and what we don't know with COVID and how this relates with smoking as well as lung damage. These are all concerns, and so there may be a rise in this. I just want to also note that this data does include over 40,000 people deaths that are related to secondhand smoke. We do see a short life expectancy among those who are smokers compared to those that are not smokers, and that quitting at an earlier age, but quitting at any time point is always beneficial, but clearly quitting at an earlier age does help reduce this. And so you can reduce dying from a smoking related disease by about 90%. A lot of this information, I'm happy to answer, receive emails or answer other questions, but I do want to note that this information is provided by the CDC. So if there's something else that you would like to look up, there, it should be there. And feel free to email me afterwards. With regards to cancer epidemiology, so you may all be familiar, but it is the study of patterns in cancer in the populations. And we do aim to look at risk factors for cancers. This includes susceptibility, causes that we can avoid, but also looking at inherited tumor susceptibility and provide sort of ways in which people could be screened or other things that may be able to reduce their risk despite their tumor susceptibility. This also looks at factors that may influence cancer progression, survival, and survivorship. And it plays a critical role in many other cancers. And you'll see that tobacco starts to influence every single one of this in terms of cancer risk, as well as cancer progression, survivor, and survivorship. So cancer is a huge public health problem because we have seen a decrease in heart disease and then a rise in cancer. And it is if you look at the map of the United States, this is wherever in blue is showing that cancer as of 2014 was shown to be a risk, the primary cause of death compared to, and heart disease being the second. Everything in green is showing that heart disease was the #1 cause of death in both 2000 as well as in 2014. But this has slowly also been changing. So we will slowly be seeing more blue across all the United States. So the cancer sites, this is something that you seem to all be familiar with. That was a great job with the polls. So then again, there are 4,000 plus compounds, and I use this, I say 4,000 plus because we actually don't know everything. The tobacco industry is very ahead in that game, whereas where they keep on changing the compounds and they keep a lot of this documentation secretive. But we do know that there are many that are established lung carcinogens as well as animal carcinogens. And there are at least 12 sites. And I use at least because that's very important, because this can constantly be evolving. There are more studies such that may provide additional evidence showing that another cancer site may be associated with smoking. One that was recently added actually in the last decade was colorectal. There is a subtype that has been associated with the increased risk due to smoking. So here, mouth and throat, voice box, so there's the larynx, acute myeloid leukemia, kidney and renal pelvis, uterine cervix, and again, the question is how? So it is associated with an increase among those who HPV is the primary risk factor, but at the same time, smoking can reduce one's immune system. And by having a lower immune surveillance, factors like certain infectious diseases, if one has that risk factor as well, maybe an increased risk of developing cervical cancer. So urinary bladder, esophagus, lung, liver, stomach, pancreas, as well as colorectal. Clearly, this is all sort of sites that were really, when one smokes, it seems to be, affecting. These are direct organs that are exposed to cigarette smoke, such as the mouth, the voice box, and the esophagus, as well as the lung. But the fact is, all the chemical carcinogens that are there may be, the other organs in the body may be exposed to those carcinogens, as well as the fact that when we metabolize things that are xenobiotic, like foreign to our system, as well as carcinogens, they're being broken down by enzymes in the liver, as well as they're being excreted by the kidney and the bladder. And being that excretion process and metabolism process is what allows the body to be also exposed to these tobacco carcinogens, and thereby tobacco cigarette smoking carcinogens. And thereby it does increase the risk for these sites. Also, I'd like to mention, here we don't see something like breast and some other common cancer sites, but there are studies that have shown that survival is decreased when one is a current smoker and they are diagnosed with one of these non-smoking related cancer sites. So it is very important that we keep the smoking prevalence very low, if not eliminated, in our society. So we've seen this already, but I do want to mark this where you can see this little up and the turn of the decrease of smoking prevalence. And this is very important when it comes to studies of cancer epidemiology, because we see this curve when it comes to the death rates by cancer sites. If you look specifically at lung bronchus, which is highly associated with smoking, that you can see the exact same sort of pattern earlier. And this happens actually 25 years later. So it is there is a long sort of induction period where when one is smoking and the risk of developing a cancer over time. So the 25, 30-year mark is that this is actually quite accurate. I do want to point out that we are seeing an increase in pancreatic as well as liver bile duct, and these are also known smoking-related cancer sites. The reasons for this is not attributed entirely due to smoking, but being a smoker does not help this. It does still remain to increase risk. This is for women. So this was the graph for men, and we see exactly the same thing for women, but a delay on that is because on average, women did start to smoke later than men in the US. And again, there's an increase with the liver cancer. So something else to know is that cigarette smoking has changed over time in the US. This includes an increase of using filters and sort of an increase in the decrease of tar use. So basically there's less tar in our current cigarettes. There's always been sort of menthol. And this change in composition is actually influencing a lot of the patterns that we see in lung cancer. And possibly as well as other cancer sites, but it's harder to detect since those other cancer sites tend to be a lot rare compared to lung cancer. So if we talk about the composition, the change in the composition of cigarettes, these are just to name a few. So I guess the increase in filtration, the lower tar, the lower nicotine, and the porous paper. I apologize for that typo. It has led to smoking changes in smoking behavior. So something like lower nicotine may result if one is already addicted to nicotine and wants to maintain a certain systemic high. By lowering the nicotine, it may result in people sort of smoking more intensely, deeply, and then also the filtration has led to where that allows for less particulates to enter in to the lungs. But then by having that low filter in the cigarette, it also could result in having smaller particulates now enter in. And then that has resulted in what we see actually a change in the common histology types. So there are 4 common histology types in lung cancer. It's adenocarcinoma, squamous cell, small cell, and large cell. And you can see that the squamous cell, which is in pink, has been sort of decreasing, but adenocarcinoma has been increasing over time. And this in part is due to the changing composition of cigarettes. And what will help is to look at the lung anatomy. So here, the squamous cell tends to be along this, the sort of inner area of the lung, and then in the outer periphery is where one would see the adenocarcinoma. And so you can see that if we're thinking just from just the small particulates, and again, this is only one hypothesis, it's not the entire determinant of what is leading to the increase in adenocarcinoma, but the smaller particulates may be able to go down into the further of the periphery of the lung. So this is just sort of showing all the different pathways. As you can see that there are a number, and you don't need to take anything home other than what is in red. And that is just to show that it can weaken one's immune system, damage cells. This includes damage of DNA, and then it can increase inflammation. And these are all things that can not only result in an increase of lung cancer risk, but also a lot of other organs in the body. And that's why, as of now, there are at least 12 sites that are associated with lung cancer. I do want to conclude with a little bit more information on lung cancer. And the only reason I like to say that is because I know we showed curves that showed decrease in lung cancer, but you can see that this is data from our Hawaii Tumor Registry, and that the incidence rates of lung cancer as well as the mortality, so what's in orange is the mortality and the green is the incidence rates, do vary. This is for males and this is for females. They do vary across the populations. So this is very important to address these disparities. So here at the University of Hawaii Cancer Center, we have been examining why. And then one, hypothesis could be just, well, some of these people might be smoking more. Maybe certain populations have a higher prevalence of smoking. And while yes, that is true, we found that even when controlling for smoking, so this is just a snapshot of 5 different racial ethnic groups that are in the multi-ethnic cohort study, which is funded by the NCI, and it is at the data here is at the University of Hawaii Cancer Center. So African Americans and Native Hawaiians are at much greater risk even after controlling for known risk factors as well as their smoking history compared to whites. And then it's been observed that Japanese Americans and Latinos do seem to have a slightly lower risk. This is consistent for those that are both in the low smoking category as well as the heavy smoking category, and the CPD stands for cigarettes per day. So in order to understand that, we continue to do a lot of work here at the University of Hawaii Cancer Center, and we have some collaborations with University of Minnesota, as well as USC in California. And what we have found so far is that per cigarette, there is, among African Americans at least, there is a greater dose of nicotine, sort of internal smoking dose per cigarette. This includes carcinogens as well as nicotine. And then among the Japanese American populations, it is lower. This in part can be explained by different genetics that result in metabolizing nicotine differently, that may allow for some groups to have a lower lower need to smoke intensely because they're able to maintain a nicotinic systemic high. This is not clear for all the populations. Again, we do not understand why African Americans have a higher dose per cigarette. And this is not consistent with the Native Hawaiian and the Latino data to suggest why the Native Hawaiians have such a high risk of lung cancer. So we have continued, we are actually developing a number of additional studies that are looking at behavioral, environmental, genetic, and epigenetic work here at the University of Hawaii Cancer Center to understand what could be driving all of this. So this is also to be continued, and hopefully in the future years, I can speak again to and have some answers for you all. With regards to smoking and COVID, again, this is so novel that there's a lot of papers that are coming out, but we're still learning. But this is one There was a systematic review that was conducted. It was very well done, and it has shown that smoking is a risk factor for the progression of COVID. And I'd also like to remind the audience that adults with the following: cancer, chronic diseases, COPD, heart conditions, have an immunocompromised state, obesity, and diabetes. And this is that many of these can be is due to smoking or can be exacerbated by smoking. So the condition of one's immunocompromised state could be weakened if they are a current smoker or being exposed to secondhand smoke. And so these are all it increases the risk of severe illness from the virus that causes COVID. And that's why it would be important that if anything at this time that we try to look for means to reduce the prevalence of smoking as we continue with this pandemic. So I do want to end with how to quit. Here at the Cancer Center, if you have any additional concerns of how to quit, I'm sure we have a lot of resources that can help. I'm happy to answer other questions, but really express to others that you have a desire. Community support is very important. Do talk to your doctor, remove your cigarettes so you reduce the temptations. And here are a few sort of quit options that are available. So if you know anybody that is interested in quitting during this time, it is a nice time to start. So thank you again for your time. And I guess questions will be answered later.